Hello, this short video is to explain how breast imagers work with interdisciplinary teams to improve patient care. What your interdisciplinary breast team is called will vary by institution, as will the number of its members and the type of its members. But generally speaking, it involves some combination of radiologists, breast surgeons, plastic surgeons, associate providers such as nurse practitioners who have expertise in breast care, oncologists, radiation therapists, pathologists, geneticists, and then counselors or other support services such as physical therapy. So what is the role of these multidisciplinary teams in the care of breast cancer patients? Well, the primary goal is to be able to provide holistic, individualized care to each and every breast cancer patient that aims to maximize their disease-free survival while minimizing their complications, their breast deformity, stress, and anxiety. There are other goals, however, which can be achieved by this collaborative approach to breast care. It means that specialties are able to update each other on the latest research within their field. They're able to enhance and coordinate research collaborations, and don't underestimate the value of this mixing with our colleagues and sharing information to build interdisciplinary collegiality and cooperation. And we found this is hugely valued at our comprehensive breast program. There are a variety of different venues where various combinations of these clinicians may meet with radiologists, including the Radiology-Pathology Conference, at tumor boards, at multidisciplinary clinics where patients can come and meet a surgeon, a plastic surgeon, a radiation therapist, an oncologist all in one appointment, as well as during ad hoc consultations between the radiologist and a variety of these different clinicians. Whenever we interact with a member of the team, we really need to think about where can we add value. These are very time-consuming exercises, preparing patients for tumor boards, meeting with surgeons at interdisciplinary clinics, and so on. It's very time-consuming. There is no RVU reimbursement for any of these activities. So we've got to think about where we can add value to improve patient care to the clinician beyond them just reading our report that we've submitted. So how can we do this? Well, sometimes we need to clarify the findings in the report for the clinician, show them the true extent of disease, or clarify findings on CT, PET, or bone scans. We may identify additional areas of disease or contralateral disease, and this particularly occurs in reinterpretations of outside studies, and it's the protocol at our institution that any patient who will be presented at any of these type of interdisciplinary clinics or tumor boards have a formal reinterpretation of their outside studies performed. Where else can we add value? Well, we can improve the quality of our radiology reports if we really know what they want to know from that report. We can reduce unnecessary or inappropriate imaging by identifying the ideal imaging algorithm for that particular patient. We can contribute to identifying patients who may be suitable for research trials, and sometimes they need us to give very specific data for research protocols, such as interpreting studies using the RECIST criteria. The imaging we review may not only be restricted to the breast imaging, mammographic ultrasound, or MRI, but may also include CT, PET scans, bone scans, etc. In fact, pretty much any study the patient may have undergone. At our institution, we meet with the surgeons at the multidisciplinary clinics to review any new breast cancer diagnosis patients before they see them. And what do they want to know? Well, they want to know the tumor size, the type, the site, whether there's any multifocality or multicentricity, either known or we suspect from our review of the imaging. Do we think this patient needs any additional imaging, such as ultrasound or breast MRI, to further stage them? Is there any involvement of the chest wall, nipple, or skin, or is the tumor very proximal to any of these structures? And do they have any known or suspected nodal disease which needs to be worked up further? We can can also be helpful by telling them if there are any specific needs for them to surgically localize a tumor, either by needle localization or perhaps a bracketing needle localization. Has the clip migrated and needs to be taken into account at the time of needle localization? And we can also make our staging recommendations, such as breast MR, or recommending that this patient has a CT of the chest, abdomen, and pelvis, when perhaps normally they would not be or have this ordered for them. So let's talk now about the tumor board setting. So like most tumor boards, this is going to be multidisciplinary. It's usually done on patients who are post-surgical or post-staging. However, sometimes it may be pre-surgical in complicated cases where the surgeons need some guidance, or if the patient has undergone neoadjuvant therapy and they want to see the effect on imaging of that neoadjuvant therapy. So what happens at these tumor boards? Well, there's a lot of decisions are made. Does the patient get recommended to undergo chemotherapy post-surgery, or in some cases neoadjuvant? Do they undergo radiation treatment? Are there any research trials that they could potentially be enrolled in? Do they get referred to plastic surgery or genetics, or physical therapy, support therapy, and so on? How an individual tumor board session is run is going to depend on your institution, but broadly speaking, it's going to involve a case presentation by the clinician. Then the radiologist will show the key radiology images, not usually everything, it's too time consuming, but those particularly that show the size and the extent of the lesion, any nodal or metastatic disease, and the neoadjuvant pre and post imaging if that has occurred. The pathologist usually shows some important pathology images, and then there's a clinical management discussion followed by a discussion about any research trial. The most important question that you need to ask yourself when you're reviewing these cases is what imaging features on any modality are present that may affect their subsequent management, and really highlight those to the group. And let's finally talk briefly about the Radiology Pathology Correlation Conference. What are the goals of this conference? Well, it's educational for both the faculty and the residents attending it to learn about the pathology and the imaging, depending which side you're coming from. But it is most important to be able to confirm radiology pathology correlation, particularly in certain cases, such as those that have unusual diagnoses. If the biopsy has come back showing normal breast tissue or some sort of non-specific diagnosis, if we think that the sampling is limited, for example, not many calcifications, or are we sure we got the right lesion, maybe the clip is in a different place than we expected it afterwards. And then it's especially important in anyone that you feel that there is a non-concordant result, such as if a BI-RADS 5 lesion comes back with a benign pathology. And we've also found that this is a very useful venue to be able to decide on the management of borderline lesions, such as ALS, in individual patients, or patients who have had small radial scars that have been almost completely excised. So what images do we review? Well, the key diagnostic images obviously are going to vary between patients, but generally speaking, if there's a mass or an asymmetry or architectural distortion that has had core biopsy done, you're going to look at the mammo and the ultrasound. For any calcifications, you need to look at the magnification views. For MRI biopsies, you want to look at the pre-biopsy diagnostic scan, as well as the biopsy, gadolinium enhanced sequence, the CAD, and the biopsy cavity following biopsy to make sure there's been adequate sampling. You should look at all specimen radiographs and all post-clip mammos to make sure the right image was biopsied and there was no significant clip migration. So that was a very quick tour through the role of the radiologist in breast cancer interdisciplinary teams, but I hope it gives you a little guidance, and I hope if you are a trainee that you get to be involved and present at one of these conferences, as I think it's a very useful learning experience.